Hello and welcome to day 5 and the final day of Brain Awareness Week 2026. Thank you everyone for joining today's webinar, which is a migraine Q&A session with neurologist Dr. Michael Eller. Next up, for those of you who are new or don't know much about the Brain Foundation, I'll just briefly introduce us. The Brain Foundation was established in 1970 and our mission has 3 main goals. First is to fund high-quality Australian research into brain diseases, disorders and injuries. Second is to provide medically reviewed resources to help people learn about these conditions. And lastly is to raise awareness about the impact of brain diseases and advocate for patients. And just to make sure you're all in the right place, today this webinar is for anyone who is living with migraine or headache, if you're a patient, partner or caregiver, and if you'd like to connect with others, and of course for today, if you'd like to ask a question. Now I'd like to introduce today's speaker, Dr. Michael Eller. Dr. Eller specializes in the management of headache disorders such as migraine and trigeminal autonomic cephalgias, such as cluster headache. This includes the administration of injections for the treatment of migraine and the TACs. He also manages other general neurological disorders such as vertigo, cognitive problems, multiple sclerosis, neuropathy, and epilepsy. And between 2012 and 2014, Dr. Eller was on faculty at the University of California, San Francisco, which is attached to the UCSF Headache Center under Professor Peter Goadsby, where he conducted clinical and functional neuroimaging research and maintained a headache clinic. He has previously worked as a visiting specialist at Monash Medical Center and Royal Darwin Hospital and is currently at Monash Neurology. Next up, I'd like to introduce Carl Cincinnato. Carl has lived with migraine for over 30 years and leads our division, Migraine and Headache Australia. He works to help lift the global burden of migraine via Migraine and Headache Australia and a number of other global coalitions and working groups. He's a member of the International Headache Society and the founder of the Migraine World Summit, which actually just finished a couple of days ago. So I'm not sure if any of you were able to tune in, but that's always another fantastic event to learn about migraine. He is a public and passionate patient advocate for migraine, and he's spoken nationally and internationally on TV, radio, and in print about migraine and the need to increase research funding, reduce stigma, and increase patient support. And now I'll be moderating in the comments and chat for today's session, and Carl will be hosting. So I'll hand things over to Carl now to introduce Migraine and Headache Australia and start the Q&A.
Thank you, Anik, for the introduction. It's a pleasure to be here. I'm excited for today's session with Dr. Michael Eller. Before we jump into your questions, we'll just talk very briefly about Migraine and Headache Australia, which is a division of the Brain Foundation. We really have kind of 3 core pillars, and the first is to provide trustworthy, reliable information, and who better to help us do that today than Dr. Michael Eller, who's part of the leadership team of the Australian and New Zealand Headache Society. We also fund research, and we advocate and support people living with headache and migraine disease. And we've been doing this work since the 2000s, for over 20 years now, to support the more than 5 million Australians affected by migraine and headache. And in fact, we recently did some research with Jean Hales for Women's Health and discovered that that number is probably closer to 6 million Australians now today. So with that, we'll jump into our Q&A, and if you have questions as we begin answering, or if the answers trigger another question that you'd like to ask, you can go into the question function in the menu, as Anik pointed out, and look at the questions that are there. Upvote those questions, and also add yours if you don't see your question in that list. So we'll kick off with the first question for Dr. Michael Eller. What are the best non-prescription medications over the counter for migraine?
Thanks, Carl. And like you, looking forward to having a really good, productive session. I'll do my best answering each of these questions. A small qualification around the intro. I haven't updated my CV online for about a decade, so it's a little bit of a legacy one. I'm still attached to Monash University and Monash Medical Center, but not working at Monash Neurology anymore. In terms of so non-prescription medications, the mainstay, this is where most people start off in managing headaches and migraines. Go to the pharmacy and see what's around, try the same sort of stuff their friends have tried or their parents have tried, that kind of thing. things to try. There are a few different categories. One category is non-steroidal anti-inflammatory drugs. And so they can include, in Australia, that tends to be ibuprofen or ibuprofen, which is typically at around 400 milligrams a day. And there are several different brands. Sometimes they're combined with other things like paracetamol. Um, there are some newer preparations with caffeine as well. I'd just be advised, a point of caution around that. Overuse of caffeine in individuals, can make headaches more frequent and intense, but that's an individual thing. Not the data for that actually isn't that strong. So, many migraine specialists will say come off caffeine, but the data for that isn't quite there. But it's still something that many people try as part of their journey, even without that. So that non-steroidal anti-inflammatory drugs, aspirin sits sort of as part of that, sort of within that category, depending on how you want to look at it. The typical dose used in migraine is 6 to 900 or even 900 milligrams or even a gram. If you took 100 people, there'd be relatively more people that would respond to high dose aspirin than high dose ibuprofen, for example. So aspirin comes in a few different forms. It can be soluble, like Aspro Clear. Sorry to use a brand, and it's dispersible, and then you can drink it. And there are other formulations like Dispirin Direct, where you can literally chew 2 or 3 tablets, and then followed up with a drink of water. That way, you don't need to carry a cup around. That can be quite discreet and can be helpful. Other non-steroidal anti-inflammatory drugs that I didn't talk about are things like Voltaren or naproxen. It's an individual thing, so you should be trying each of those a few times, get a feel for it, see how you tolerate it. All of them can irritate the stomach, and things like ibuprofen and Voltaren, if you use them for decades, it can increase risk of problems with kidney dysfunction, blood pressure, cardiovascular risk. So they're not without potential issues. Aspirin, of course, can increase bleeding risk. Another category, and I'll try to keep my answers shorter than what I'm doing right now going forward. Another category that's become available now in the last year, triptans. So they're serotonin, specific serotonin agonists that were developed for migraine in the 80s and 90s. They've been available for 20 years, and now you don't need a script for them. So you can literally walk into a pharmacy and get 50 milligrams of sumatriptan or a dose of Relpax. So I'm using Eller or rizatriptan. It'll depend on availability. It tends to be a bit more expensive than with a script. So as long as you don't have a history of cardiovascular disease or stroke, you can, because triptans are vasoactive to around 10 or to a small degree, you can try triptans, and they could be combined with um, anti-inflammatory drug, and alternatively, you can use an antiemetic if you need to. So the upshot of all of that is try and build a toolkit which is reliable, effective, and well tolerated. And if you're using it regularly, that's a flag to you. You need to be talking to your doctor about potentially looking at a preventive, or trying to mitigate things that trigger. But typically it's hard to eliminate everything that triggers, because we all live in the world. Far too long an answer. I'm going to try and keep it shorter. Carl,
Thank
anything else you want to say around that?
No, I mean, this was the top question that was voted for. So I think it is worth spending a bit of time breaking this down. And you spoke about triptans being vasoactive. Does that mean that it affects the blood vessels? And if someone has a history of heart disease, it is something they should probably speak to their doctor about first?
Precisely. So, so I dropped a bit of lingo there. So, what I mean by that is they were actually developed to be vasoconstrictors, so to make arteries a little bit tighter. It pertained to an old theory of migraine that isn't current anymore. So they do, because they can change the dimensions of arteries, you'll see if you're suffering from angina or you've had a heart attack, the last thing you want is your heart arteries to be a little bit smaller and then and give you a heart attack. So yeah, if you have any history of those sorts of problems or peripheral vascular disease, at the very least, don't just jump in and use the drug, but talk to your GP and have the conversation about whether it's a reasonable thing to do or not.
And then you mentioned that we can purchase these over the counter. Do you need to have a diagnosis of migraine? Do you need to have like a history of using them? Will the pharmacist block you if you haven't been diagnosed or have never used them before?
The wonderful question. I don't know. I'm I would hope not, because many people with migraine, basically, essentially, if you've got at least moderate headache, with or without some other symptoms like light sensitivity and nausea, you've probably got migraine whether you've been diagnosed by your GP or a specialist or not. So I would hope that if you're going to the pharmacy, you'd be able to try that medication if there are no reasons, not to. Um, by the way, if a drug like sumatriptan is helpful, it doesn't prove you have migraine, but they're not diagnostic tests per se. But no, I'd hope that the pharmacy wouldn't be saying no, 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 you have to have a diagnosis, because this is the problem. Like there are lots of parts of Australia where access to the right people is difficult.
Hmm. Yeah, okay. And then you mentioned non-steroidal anti-inflammatories, so things like aspirin and ibuprofen, but they don't come without their risks. So you mentioned that they can irritate the stomach,
Yep.
and if they're used over decades, they can potentially cause serious problems if it continues to do this damage over time.
Yeah, yeah, exactly. So, a lot of people like I'd say it's actually more, the routine standard thing that most people with migraine, the journey they go on, where, they're using ibuprofen. In America, they use naproxen. Um, Other countries more inclined to use diclofenac, which is Voltaren. One brand is Voltaren. People tend to rely on these, and then and can often use them just for years, whether they're headachy or not, because they're trying not to be not to have intrusive migraine symptoms, and they're just trying to get by. So yeah, if you're using them regularly, it's not uncommon to get gastritis, so an inflamed lining of your stomach. Uh, Iron deficiency is not uncommon in people who use non-steroidal anti-inflammatory drugs regularly, and that's another problem, because you're just bleeding, essentially. And yeah, it's sort of not that widely known, but medications like ibuprofen used for decades, well known to increase cardiovascular risk. So it just because it's over the counter doesn't mean it's without risk.
Yeah, that's good to know. And does that risk um, is that offset when we have something in our stomachs? Because typically we say consume with food, right? And that kind of helps the gut protect, get some level of protection from the treatment. Or can
Yeah,
these issues still arise despite
they
always
can
having some food in your stomach when you take
they
it?
can still arise regardless, but particularly if you're just using it as a now and then thing, if you take two ibuprofen and then sip a bit of water, then go lie down, you're a bit more likely to have reflux symptoms or feel a bit irritated, as opposed to taking the two tablets with your breakfast in the morning. Um, but yeah, no, like even taking it with food, you can still get all of those problems. So, for example, some drugs like indomethacin, diclofenac, are available as PR medications, which can be useful. They need a script though, I think, and they're useful now and then medications for people with migraine with significant nausea and vomiting. Not very widely prescribed, but can be useful. And people who receive the medications in that form, they can still get gastric disturbance, just to sort of emphasize that point.
So if anyone's been taking these medications for years, maybe on empty stomach, don't have any symptoms, should they check in with the doctor about that? Should they be worried, or should they be try to be just a bit more diligent going forward.
I think if you're using it really regularly, as a matter of routine or because it's helpful and that's just been the pattern, yeah, there are reasons to be extra assiduous, check in with your GP about managing your cardiovascular risk. That's like blood pressure, diabetes or pre-diabetes, cholesterol, all of those sorts of things. But it's also like um, checking in, should you be thinking about other ways to mitigate or diminish your regular use of these drugs going
So, Dr.
forward?
Ella, I know I'm going to sort of put you in a box here, but like, what's the amount that's like, okay, you probably should be thinking about speaking to your doctor about it. Is it
Yeah.
8 times a month? Is it 15 times a month? What's that
Yeah.
threshold in your mind?
Yeah. Well, I think if you're getting symptoms from the drugs, but they work, I think that's a reason to see the GP. If you're, I think you know, you once you're the person that always has some in your bag because you don't want to be anywhere without it, and you're using it a few times a week, maybe even most days, to try and avoid any trouble, um, then or you always take it if you're sort of going out after work just to avoid any worsening possibility. Like if it just becomes a routine thing and before you know it, using it a third half the month, then that's telling you, okay, this is maybe helping you get by, but it's not, and it's okay for a few weeks here and there, or even a few months here or there, but it's not the right setting over years and
Yeah.
certainly over several months.
Yeah. We should be thinking about prevention and preventive treatments in that instance.
Yep.
One last thing about this question, and we'll move on. I promise we've got more questions, and I can see questions coming in through the Q&A. So thank you for those. And if you haven't, go into the Q&A and upvote those questions that you want to get answers to. The thing that I wanted to touch base on this as well is sometimes maybe the best sort of strategy isn't just one medication, right? So you mentioned an antiemetic, which is anti-nausea, which is great if you experience nausea or vomiting with your medication,
Mhm.
and particularly if you're taking an oral tablet and you've got nausea, that medication, as far as I understand, is going to struggle to be absorbed. And so combining that treatment and having a combination can sometimes be synergistic.
Precisely. I can't recall if some of the commonly used anti-nausea medicines in Australia are actually available without a script. So I'm not quite sure, but commonly used medications can include metoclopramide, prochlorperazine, ondansetron. Sorry, I've used the real names or the medical names for
That's
them.
fine. I think that actually helps people. Like we're not, yeah.
Mm. And the reasons historically medications like metoclopramide, uh, that's one of the three I mentioned, that can actually improve the way your guts wriggle. It's called gut motility. And some people get some degree of gastric stasis in the context of a migraine. So and those drugs can be helpful, like prochlorperazine and metoclopramide in particular, can be helpful in treating the migraine itself, as well as helping with nausea. They do tend to work a lot better intravenously in the emergency department, but they can have some use orally. The point of caution around those drugs, if they're used regularly, you can get other problems from them, such as a feeling of restlessness or Parkinsonism if used most days. They're also often used for, or at least prochlorperazine and metoclopramide can be used for vertigo associated with migraine as well. For the,
I also heard that they may have some pain relieving effect in their own right, sort of
yeah, well,
paradoxically.
well, it can help with the migraine directly, and that could be any aspect of migraine. They're dopamine antagonists. That's the class of drug they're in. So yeah, it can help with pain in individuals. So for some people, it's a really useful add-on.
Mm.
And that's why I was talking about a toolkit. Some people they're using a couple of ibuprofen for mild headaches. They feel like they're getting into a more troublesome migraine. It might be a combination of they're not maybe they've got nausea with it, so they avoid the ibuprofen, which makes that a bit worse in that context. And they're using sumatriptan plus metoclopramide, just for example. So, really, the big takeaway is there's no one right drug for an individual. you need to try to play the field and try different things and work out what's the best tolerated and what works best for whichever situation, and even combinations. I haven't talked about paracetamol. Most people with migraine don't find that especially useful. Many people take it anyway because it just feels better somehow to take something that might do something. Um, but there are individuals that do get some benefit, and that can, if you're that person, that's awesome. That's lucky, and you can always add that into the mix too. Tends to be
Great.
well tolerated.
Excellent. Thank you for a really comprehensive answer on the most popular voted question that was submitted. Let's go to the others because I know there are plenty others and I can see some coming through in the Q&A, so we want to have
Yeah,
time for
lots
those
coming
too.
through. Yeah.
So what is the relationship between neck pain and migraine?
Okay. I'd say a very intimate one. 5-year-olds and 50-year-olds tend to have this problem. It's almost ubiquitous. Like almost everyone prone to migraine has neck discomfort associated with it. It can often sort of lead. It can be part of the lead up to when you're getting migrainous. You sort of maybe you wake up with an uncomfortable neck and migraine builds over the day, or or it starts later in the day. Aniak, I've got a slide to show if you can in the background. Um, the I'm just going to show you this because for people seeing physiotherapy, osteopathy, an osteopath, etc., uh, people tend to get told that it's the problems in their neck. Um, in some individuals, there could be some contribution of problems within, wear and tear in your cervical spine that's plausibly feeding into the mix. And if you've got a predisposition to migraine, it'll make it worse. But the reason I want to show you this scan, I don't think I can move the cursor around, but think about it like this. Uh, Migraine itself is a dysfunction of your brain. Part of the circuitry triggers a lot of uh, downstream effects from the brain into muscles in the neck and pain structures in the neck. So it makes neurological sense. So that the pathways are very established about why migraine itself would cause neck discomfort and you feel like it's coming from your neck. That said, and the other thing is, once you're getting into your 40s, 50s, 60s, people get more and more wear and tear in their spine, just age-related changes, just like you get osteoarthritis in your joints. And that tends to start impacting on nerve structures to some degree and other structures within the neck. It tends to be the middle to lower part of the neck when people get imaging, and that's much less likely to be feeding into migraine disposition. So, headache and other migraine symptoms like light sensitivity. So with all that said, if you stimulate individual nerves in the neck, and that's what, sorry, I can't point to the actual, if you go down the cursor, the
Let me
bottom
know.
right,
Yeah,
yeah,
let me know where
and
you
yeah,
want me to.
yeah, exactly. So the bottom right of that screen, um, if that shows a number of different, if you stimulate, there are 6 pictures of a head there. If you stimulate each nerve root at C0, at 0 to C1, C1 to 2, C2 to 3, then you actually in this spread of I think around I can't remember how many people this was tested in, but tens or hundreds of people. Basically, if you stimulate with electricity um, into those areas, you get discomfort in different areas and different people. So it's interesting. In the textbooks, it'll just say that part is C2 and the others won't have any impact with discomfort here. But actually, when you stimulate the nerves directly, you do get discomfort in areas commonly affected by people with migraine, not just at the back, but also at the front. And it's different in different people. The other sort of interesting study is the circuitry is just above those heads. That was what I was talking about right at the beginning. So that's why there's crosstalk and an intimate relationship between the two. It is a two-way thing, by the way. Um, and so the image on the left is it's a study from LA from about 10 years ago, and they took 10 people. The first six had migraine, the and the last four did not. When you stimulate C1 in the people with migraine, they get discomfort on the same side of the head at the front. And when you stimulate non-migraine sufferers at the same spot, the discomfort's at the back. That's kind of fun, right? So it just shows the circuitry is different in different people, and the way you experience things is really variable. So I mean, this sort of relates to. I'm going to segue into, so what's the role of physiotherapy or massage, and can it help? I'm just sort of interpreting the question that way, or are there any special techniques that can be helpful?
Yeah, our next
Um,
question. Absolutely. Go
and
ahead.
I'd say it like this: if you find a practitioner that you find that um, that's doing things to the neck and head that you find very useful, that's fantastic. You know, it's so common for all these structures to be tight and uncomfortable in migraine. You know, there'll be at least 10 or 20 people online now that always that have gone on journeys for trying to find the perfect pillow. You know, for example, or maybe even more. Like it's a sort of a normal part of the journey for a lot of people, especially with very frequent headache. And most people would have tried different remedial masseuse or other techniques. Uh, you know, dry needling, which I think Carl talked to in a second. Basically, all of these different techniques can be helpful in individuals. Sometimes, and especially when people are relatively more migrainous, they can trigger as well. So they can be helpful or they can trigger on individual days. The only point of caution I'd say is, in particular, seeing chiropractors, I'd avoid cracking the neck. I have to say that as a neurologist, just because I see occasional people with stroke from torn arteries, like from that procedure. But that's a very rare bad luck side effect. Most people who get their necks cracked never presenting to a hospital with a stroke. So that's just my bias, because I see that sometimes. But you know, almost all those interventions like physiotherapy, dry needling, acupuncture, they're safe. It's usually a question of finding a practitioner where what they do doesn't make it worse and you feel comfortable with their approach. But the data is not really there, so I can't say Watson's better than Bobath or Bobath is better than dry needling. What's your take on this, Carl, on the whole space?
I think it's really individual. I've gone through a number of different chiro, physio, osteopaths myself personally, and I signed my life away when I went to the chiropractor. Like, you know, they talk about the risks and all sorts of stuff, and I can't say that it's something I use regularly, but I do enjoy just massage. So not actually seeing a physical therapist at this point because I don't have structural issues with my neck that need to be addressed. But I do find sort of, you know, massage, which is just an indulgent thing to do. I feel like, at least for me, is really relaxing. But I know that for other people with migraine, it's a trigger. So I think it's just really individual. And the other thing I would say about neck pain is I have bad posture. And as soon as you talk about like the neck and posture, I kind of sit up straight. And I actually find doing sort of regular exercise like almost like a preventive treatment for my neck stiffness and bad posture. Like nothing too crazy, but I just find that like when I don't exercise, when I'm unwell or I'm sick, after a couple of days, I get a stiff neck, my back starts to hurt, and everything kind of like all these other ailments seem to appear, and it just seems to be kind of managed by just a bit of exercise, actually.
Yeah, Carl, I love that comment because it's really clever. It's I think that's the journey a lot of people go on. You know, there's plenty of data. There's actually some data around exercise itself. So yeah, exercise can trigger migraine for a lot of people too, but most people, many of the same people actually find that if they can get away with exercising regularly, they're actually less migrainous too. Funny paradox. Ergonomics, absolutely. And I'm sitting up straighter now as well because of that comment. Like, yeah, if you can optimize your seating position, where the screen is in front of you. It's a bit low where I'm sitting. Um, I- Basically, with migraine, you do everything you can to maximize your chance of just being as migraine free as possible, and everything feeds into the mix.
Hmm.
Um, and yeah, I'm with you. I've got many patients who, I'm iterating with medications and giving some advice around some other things, but many people have a physio or a remedial masseuse or the osteopath they see regularly, and for many of them, it's a really useful add-on.
Yeah.
Um, I, I don't dispute. I think that's exactly right. So you go with what works for you.
Yeah. And if there are
But
people that have migraine triggered by exercise, like let us know in the comments. We can answer a question about that because it's not a life sentence to say you can't exercise. There are ways to build up gradually. But
yeah,
we'll jump now to the next question, which is about pain and the location of pain meaning different things. So if our migraine expresses in the forehead, on the side of the temples, I know some people it's right behind the eye, even though it's not cluster. Does that tell us anything about migraine in particular? This person said that sometimes a wet wash or a flannel on the forehead helps. I know ice really helps a lot of people as well, like right onto the spot. What's your tell?
yeah. Listen, it's really interesting. I think for the most part, it doesn't direct medication treatment. So if someone's got a diagnosis of migraine and it's clear, it doesn't it doesn't really change whether it's here or there or there or flicks around or moves from here to there. When it's sort of a relatively more fixed position, it makes us always a bit more assiduous, like a bit, we've got to double check, triple check that there's no secondary cause, whether that's from the neck, something in the brain, something else, something in here. So it's always a sort of flag to the clinician, make sure there's no other contributing cause. I guess that's one thing. And many people do find that there's stuff they can do when they're migrainous that can help a little bit, which is local. So a lot of people press here,
Yeah.
where you've got supraorbital, supratrochlear nerves. Some people are actually pressing there just where the greater occipital nerve uh, emerges. It's a branch of the second cervical nerve root. We do steroid and anesthetic blocks of those areas sometimes, but people sometimes just press there. Other people, like you said, either sucking on an ice block or putting an ice. I saw someone 2 days ago who regularly uses an ice cap in conjunction with their triptan, and they find it really a beneficial contributor. So you can do all those different things. And again, it's a question of you can try different stuff. If it works for you, that's great. And the scientist in me says, yeah, there's absolutely some plausibility around topical treatments like cold. Sure,
Yeah.
if it helps, great. It's just not that convenient if you're working at work and
Yeah.
you need to be sort of pushing on.
Yeah. All right. Next question. Is there a non-prescriptive drug that can help with brain fog?
Yeah. The short answer is nothing specific. Brain fog's uh, is just that feeling that your thinking isn't quite as clear as it could be, or a bit of under a cloud, or um, you have good and bad days with it, or it's always like that. Many people with non-migraine problems experience that perception of how their brain's working too. So I just keep in mind that's a really broad remit. It could be many things. You might be feeling crook from some other problem and have that feeling of brain fog. In the migraine space, it is a common complaint. Um, in terms of non-prescriptive drugs, people try all sorts of different things. So maybe I'll just talk to two of those things. I mean, occasionally, some of the medications I just talked about earlier at the beginning of this discussion can sometimes make people think clearer. So if you're prone to migraine, you take aspirin, for example, and you normally find that helps for migraine. Um, uh, for many people who do that, they don't care so much about the pain, but they actually feel that they can get through their workday better and they're clearer in their thinking because of that medication. So uh, I guess that's one thing to say. Some people use nutraceuticals to go after brain fog symptoms, whether that's vitamin B2, 400 milligrams a day, or some form of magnesium, just to pick two sort of random examples. I'm not recommending them, by the way, for that indication, but they're two of the medications people which are natural therapies with some evidence base in migraine. And for some people, they find that that clears their head a little bit, even if it doesn't help that much with discomfort or light sensitivity.
Mm.
Um,
This is something that I've experienced a lot of over the years with migraine.
mm,
And when you look at the sources of brain fog, it can be due to the migraine itself. It can be due to the sleep that you've had disrupted by migraine or just poor sleep in general, which is we know is higher in people that live with migraine. And it can also be from the treatments themselves.
mm,
So improving your migraine condition will automatically help your brain fog, typically speaking, all else being equal, I would say, and improving your sleep. And if you're able to, exercising. Exercising is kind of like flushing. It feels to me personally like it's flushing the brain. And I used to feel like I was on a timer with my migraine attacks. Like it would just build up, build up. I could feel my brain getting a little bit fuzzy. And I'm like, I'm going to get a migraine soon. And then sure enough, there it goes. And with exercise, as I've been able to do, more and more and have a bit of a consistency to it, I've found it's given me that sort of defense and that flush that sort of helps me feel a bit sharper, a bit clearer, certainly more awake. So those are non-drug options, I guess, but not necessarily available to everyone. The other thing that this might be a little bit controversial, Dr. Eller, is that I had two young kids, and one of them was a really poor sleeper until recently. And
mhm.
in doing my research in that, I realized that actually there's a supplement that's used that's very well known, but is actually shown to be very good in sleep deprivation and brain fog associated with sleep deprivation, which is um, oh gosh, the name has just eluded me.
Not
Talk
melatonin,
huh?
not
No, it's not
melatonin,
melatonin.
not.
Creatine.
Oh, right, I see.
Can't
Um,
be that good if I can't remember the name of it. No, but
uh,
apparently it does have quite a bit of literature around the benefits of cognition in the setting of sleep deprivation. So if you've got brain fog, but you're sleeping, 9 hours every night and you get great sleep and you know that, then it's not going to work. But if you're sleep
that's
deprived because of some, it could be a baby, it could be migraine, it could be other factors, then that might be something to look at. And there is some research and evidence behind it, which
yeah,
surprised me because I always associated this supplement as like for gym bros who are doing
yeah,
heavy weights and stuff at the gym.
the muscle guys, yeah, for
Yeah.
sure. I haven't seen data around that and sort of brain fog or sleep quality. There is surprising data around creatine and its use, and its like the rational use in relation to mitochondrial function. So I've seen bits and pieces around that. Um, another sort of off-label thing people use is a drug called apigenin, something like that. Again, I'm not recommending that. They're just all these. Listen, for the migraine sufferers that have poor sleep, they'll know that the that shelf in the pharmacy it has about 50 different products because it's such a ubiquitous thing, and people with migraine, like Carl said, especially prone to have brittle sleep. Sleep and migraine are like this. They're really bound together, and typically you won't get good migraine control if your sleep's rubbish and vice versa.
Hmm.
Um, yeah, all really good points. Exercise can help with clarity of thinking in people who can sort of manage to sort of exercise regularly. So that's a strategy that many people adopt, just like Carl, and it can help. We've got all these questions. I'm just looking at. There's
Yeah.
35 questions in.
Yes.
Should I start going through some of them?
Yes, I will throw them at you because
Oh,
I can see
okay.
them by the number of thumbs up they're getting, so the upvotes that they've received. And at
Oh,
the
I
top of the
see. Yep.
list is a question about does blood sugar levels and dehydration impact migraine triggers or do they act as migraine triggers?
Yeah, I reckon again, this is one of those things where individuals will have different experiences. So if you feel they are common triggers, and we know this from a number of different series. So I'm not making it up, like prospective series of uh, tens of thousands of people in different parts of the world. Um, some people do feel if they're behind with their fluids or if they've skipped a meal, they become more migrainous. Um, it's a tricky thing. You speak to an endocrinologist and you say, well, is it really, and someone's wearing a glucose monitor and their sugar's 4, um, and they feel like they're low in sugar, are, is it actually abnormal, right? Um, and they'd say, well, no, that sugar's within the normal limit. But someone feels that if they eat a bit in that context, things will improve. And I don't think the individual experience is wrong there. I just think our understanding is a bit simplistic because there are, I mean, just like the introduction of these medications like Ozempic, like semaglutide, and that whole class of GLP-1 medications has taught us. Uh, Many of the medications used both in insulin signaling, food processing, gut movements can have significant impacts on brain function and vice versa. So uh, I think it's just a complex space. The uh, if you know that if you feel like you need to snack between meals so you can be a bit less migrainous, then that's a thing that's something to do. Are you literally low in sugar? Probably not. Physiological systems uh, uh, work pretty well in humans. So there's this concept of homeostasis that if any of you sort of studied human physiology, you'd go through in the first several weeks, where most your body regulates just how much water's in your body, how much water is in different compartments of your body, how many salts and electrolytes are in different compartments, and pushing glucose around, so you've got the right amounts at the right times.
Yeah.
Your brain utilizes glucose if it's not utilizing ketones. So that's sort of the physiological answer. But on an individual level, you go with what you feel like you need. That's Someone did ask about electrolytes and whether everyone should be on electrolytes. Well, not really for that reason. I mean, because of homeostasis. If you eat a normal healthy diet, you shouldn't need to add in electrolyte supplements. For individuals that are lightheaded on standing, sometimes additional electrolytes with water in the morning and the middle of the day can help a bit. But many of the products from pharmacies have all sorts of additives and sugars, which aren't necessarily good for you going forward. And it's also just another product and another input that you don't necessarily need. Listen, 50 years ago, we didn't have a multi-billion-dollar natural supplement industry. The pharmacies were a lot smaller.
And I think when it comes to triggers as well, like the lower your migraine threshold, the more vulnerable, the more chronic you are, the more likely that anything could be a trigger. And as someone who's had migraine triggered by low blood sugar, by hunger, like today, is that a trigger for me? It can be if I'm sleep deprived and I'm highly stressed and I've got these other factors that are stacking and putting me over my threshold. But if everything else is in order, I can get away with being hungry. I can get away with dehydration for a period of time.
Yep.
It's kind of one of those dynamic things that is variable, for me over time, and I think it'd be variable for other people. And particularly as you find, if you're able to improve your migraine condition, you'll be able to find that your resilience to these triggers that may tip you into a migraine are less likely to do so. Like for example, weather. Like weather, I used to get a light if there was a lightning storm, it wasn't just run for cover. It was like run to bed because I knew it was going to be a migraine. But now that's not the case because my resilience and my management of migraine is better.
Yeah. So one way to conceive of migraine is you think of it as a thresholding disorder. So, many of you will have a migrainous brain, for want of a better word. So basically the combination of genetics and environment, everything you do, you're migrainous. Now, there'll be points in your life where just think of it as a dial. The dial's turned up and you're relatively more migrainous. When you're more migrainous, you'll probably find, yeah, the crap sleep, you're going to wake up with a bad, like you'll be really headachy and light sensitive. You've got, you're skipping meals, you're exercising, weather change, all these really common triggers. Whether doesn't matter whether you've read the internet or not. These are ubiquitous triggers all over the world. Um, you if you're less migrainous, the dial's right down. You get away with deadlines, bad sleep, your kids not sleeping through the night. You don't need to eat your lunch when you're busy. You just sail on, and you're not headachy. But when the dial's up a little, you can't get away with it, and that can change. So, people like me try and spend a lot of time trying to get the dial down so you can get away with um, uh, you know, uh, being able to not live as regulated as a life,
Yeah.
and
So we can live.
you can get away with more.
Yeah. Have a quality of life and go out.
You
Yeah.
know, have a drink and get away with it if you
Joe
want.
had a question about the long-term damage done to the brain as a consequence of migraine. So I guess, is there long-term damage that occurs? And as a follow-on, Sam wanted to know about the white matter that sometimes appears in imaging and if we should be
Mhm.
worried about that.
Yep. To the first part of the question, there was a study of tens of thousands of people out of Iceland some years back. I think came out in Brain like 10 or 15 years ago, and that had a really long longitudinal follow-up, and it didn't show any increased incidence of dementia or any medical or neurological problem. So, no, I don't think there's any long-term damage from migraine. People wonder about that, especially, and it is, and I mean, beyond, further to that, if you have relatively more migraine or relatively more severe attacks, are you more prone to, problems and damage in the future? Well, no, not really. Like intuitively, you think, oh, geez, how can I suffer like this and not have a brain problem in the future? No, there's no data to suggest it's an issue. Um, Migraine in particular, migraine with aura, which is about 25-30% of people with migraine, uh, are, when you look at tens of thousands of people, a bit more prone to cardiovascular problems, in particular stroke, um, as well as other things like dissection of the artery or or even heart attack or bleeds in the brain. So there are some associations, but whether you've got good or bad migraine control, no one's really done the study to know whether that has any impact. If you've had one aura in your life, or you get 10 auras a week, does that have an impact? We don't really know. In terms of white matter changes, that's something that sort of emerged in the last 20 years. When If you have migraine with aura, especially if you're a woman, especially if you're relatively younger, you'll be a bit more prone to small uh, increased signal spots in the connective parts of the brain called the white matter. Now, they're picked up on MRI typically. You sort of usually not commented on CT. Um, Most humans have them to a greater or lesser degree, regardless of whether they have migraine or migraine with aura more specifically. But yeah, if you've got migraine with aura, you're more likely to be a bit more prone to having relatively more of them. What's the meaning of it? Well, um, microvascular changes are probably there's tiny blood vessels, so not the big blood vessels, but tiny ones that clag off and scar a little bit. And again, it happens, when you scan 100 people, whether they're 30 or 50 or 70, you'll almost certainly see some of these changes. It's part of being human. Um, they're linked with cardiovascular risk. So if you're diabetic, you've got high blood pressure, you smoke, probably vape, not sure yet. Um, if you've got those sort of risk factors, overweight, not exercising well, things like that, you're more likely to have some of those spots, but the link isn't clear. You could have high blood pressure and be smoking your whole life and get a scan at 70 and it looks normal. I wouldn't say normal. It just looks, you don't have the spots. So especially 10 years ago, a lot of radiologists would report the spots and then people are seeing the neurologist alarmed. What the hell does this mean? But more commonly now, the people who report the MRIs are saying in the conclusion, normal scan, and in the body of the report, if you see it sometimes, they'll say a few white matter changes,
Okay.
consistent with microvascular. And I'm talking about this because it's a really common problem, it's a common thing that brings people to see the neurologist. There are all sorts of different terminology people use: small vessel disease, microvascular changes. Sometimes doctors will say the words mini stroke, which is not very helpful and a bit alarming. So I hope that helps with that bit.
So really, it's common. It's not really anything to worry about. We can have them and still have no symptoms or side effects from
Exactly.
it, and we
Yeah,
don't need to be worried about migraines causing brain damage.
precisely. Yeah, it's just like any other human, especially as you get older, just manage your cardiovascular risk. If you know your blood pressure's high, don't ignore it. Just go after it.
Yeah. And there
Mm.
are changes. If we've had migraine for years or decades even, our memory, our cognition changes as we age. That's normal. Um, and and we do have cognitive side effects from medications and from migraine, right? Doesn't mean it's permanent. If your migraines got better,
Hmm.
I mean, I certainly found that with me when I went from chronic to episodic. I found that my cognition, my thinking, my memory, those things returned. Um, it was literally coming out of the fog almost.
Yeah,
Um,
100%.
we've got 5 minutes left, and I'd like to sort of try doing a little bit of a rapid fire. So we'll do sort of shorter answers for a few more questions to sneak some in, if that's okay.
Yep.
One of the questions is about migraine that includes pain, but often these other really bothersome symptoms like dizziness, nausea, light sensitivity, irritability, fatigue, pins and needles, a whole list. Is there anything that can be done to alleviate those other symptoms besides the pain?
Yeah, listen, the treatment really should be the same. If you've got an effective acute migraine therapy, it should it should work for all of those things. And if it's not, your GP or neurologist should be thinking about trying something else, because we want to be going after the symptom that bugs you the most. For some people, I might give them uh, Eller, and it doesn't do anything for the head pain, but it helps with the photosensitivity, and that's the thing that bugs them. So they're happy.
All right, let's jump to the next question. Is desensitization to sensory triggers possible in migraine? For example, like with light sensitivity or smell sensitivity. So I guess another way of phrasing it, do you believe in exposure therapy?
Yeah. People try behavior adaptation. I think it's good to try and push yourself and just try and inhabit the world and do your best. The migraine is a problem of dishabituation. This is the problem though, the person with migraine, they're exposed to a loud noise, um, and then they keep getting exposed to the loud noise. The brain doesn't decrease the signals going that come in. Whereas the non-migraine sufferer, there'll be changes within the brain, and to a degree the ear and its relationship with the brain that mitigate that incoming signal. So yeah,
Habituates.
by all means try, but again, it's if you can turn the dial down and just try and get away with exposure, that's probably the best combination.
Right. Tanya had a question about why do auras without severe migraine occur, particularly the visual disturbances?
Great question. We don't quite know, especially as people get older. they can become more and more prone to aura without migraine, without pain. Lots of terms for that: silent migraine, acephalgic migraine, um, stroke-like, late life stroke-like equivalents, all sorts of terminologies for different kind of things. We don't. The why is always the hardest question in medicine. We don't know. But it's a thing, and it's not uncommon, and it also warrants treatment if the frequent aura is a problem, even if you're not headachy or nauseous or anything else with it.
Lisa had a question about, is taking vitamin D helpful in preventing migraine?
Again, it's one of those individual things. I've never seen any data around vitamin D as a preventive in its own right in people that have normal vitamin D levels. Anything can make migraines worse in individuals. So if your vitamin D levels are low, especially if they're really low, yeah, absolutely replace it. You might be in luck and you might be less prone to headache.
Brilliant. Well, thank you so much, Dr. Eller. It was a pleasure having you on today. Thank you on behalf of everyone here. I really enjoyed the discussion. Anik, I'll invite you back on if you'd like to sort of wrap up, but thank you everyone for joining us this week at Brain Awareness Week.
Yeah, thanks, Carl. And thanks, everyone. I really appreciate the invite. Just it's a pleasure to be here. Cheers.
Thank you, Dr. Eller. And thank you so much, Carl, for facilitating today's webinar. And thank you, everyone, for being here. It's been such a fantastic session today, and also all of the other sessions during the week. There's been so many fantastic questions and topics covered throughout, and it's been really interesting seeing the synergy across so many different brain health topics, whether it's, brain health in the sense of dementia, or even some of those topics, intersect with things that you might do to improve brain health in the migraine sense as well. So it's been great to see that synergy across the week. And yeah, thank you so much, everyone, for being here. And we will share the webinar recordings as soon as we can. Two are already up on the website. You can see those in the email that went out at 7 a.m. today. But the rest will be up next week. Hope you all have a lovely Friday and a wonderful weekend.
Before we sign off, Carl,
Yeah.
on behalf of my patients, I know I have quite a few patients that are part of Migraine and Headache Australia and always tune in to Brain Awareness Week. So just thank you on behalf of all of my patients for doing the work that you both do.
Well,
Thank you. Thank you
same
so
here.
much, Dr. Eller. We really appreciate that.
Cool, cool.
Okay. Well, yeah, have a lovely afternoon, everyone. Bye.
Deal. See you guys.